We're going to talk about frontline papillary renal cancer. I don't think it'll be quite as contentious. All-star panel. I've moved into the moderator role, so it should go much more efficiently. Tom, Laurence, Hans, and David, thank you all for joining. Really, just a few slides. Let me recap SUNNIFORECAST, and I'm going to ask you each to comment. I think I have 3 slides. So this is a German-led IIT presented at ESMO. Broad non-clear cell. You see on the table on the right about 60% papillary, 20% chromophobe, and then a handful of each of the other non-clear cells. Frontline therapy, 1-to-1 ipi/nivo versus standard of care, which was by and large TKI monotherapy, I think sunitinib/pazopanib, a handful of IO TKI, and you see the other stratification and data. They picked an interesting endpoint of a landmark OS at 12 months, which we can talk about. This is the primary endpoint. I've sort of taken their slides and rearranged them. So Kaplan-Meier for overall survival on the left. Those 3 dashed lines are 6, 12, and 18-month landmarks. And basically what I've done, I've put the delta in there between standard of care and then ipi/nivo, which is on top. 5-month improvement at 6 months, 8-month improvement at 12 months, and 8%, I should say percent. 5%, 8%, and 8% at those landmarks. And you see the p-values. So they were kind of barely insignificant, then significant, and then barely insignificant again, sort of for what it's worth. Median follow-up's pretty short at 2 years, so there is no overall survival benefit. That's the hazard ratio at 0.83 shown in the upper right there. But again, pretty limited follow-up. And then you see the forest plot on the right, and I have tried to have arrows at the PD-L1, which seems to enrich in non-clear cell as it does in clear cell, and then also this chromophobe signal, which I'm not sure I understand. Let's pause here. Laurence, what did you think of these data when you first saw them?
Okay, the first thing I have to stress is that I'm conflicted. We're the top enroller in this study. I'm glad that this study happened. I think what it's showing us is A, we're able to randomize patients that have non-clear cell, including academic randomization. B, the study confirmed the fact that there is a role for IO in patients with non-clear cell entity, although I don't like to have the mixed bag, and I favor looking at different histology one by one. And 3, the study is positive because the comparator was single-agent TKI, okay? And so I think this is something we have to have in mind because we don't have a head-to-head IO versus IO TKI here.
Okay. Hans, you're an ipi/nivo kind of guy. Were you giving ipi/nivo to non-clear cell before this, and did this change your mind or influence you?
So the data was never really strong for nivo/ipi, and there was the one group where I did not routinely give nivo/ipi, to be honest with you. So I was happy to see that the PD-1 TKI combination made themselves into the NCCN guidelines. The data was very strong, 50% response rate. So that's what I'm mostly stuck with. But I think this certainly surprised me in a positive way. It reinvigorated my thinking about nivo/ipi in non-clear cell renal cell carcinoma. What I do want to see though is we need more breakdown, right? So as was indicated, chromophobe probably responds less well to immunotherapy. 20% was at PARC. So the response rate probably in papillary is going to be even higher than 32%. So I think that's a very positive signal, and certainly above what we know about single-agent PD-1 activity in papillary.
David, same question for you. And would you use PD-1 to select such patients?
You mean PD-L1?
PD-L1,
on the
sorry.
tumor? I think this is a place, non-clear cell, ironically, where PD-L1 seems to help us a little more to enrich for patients more likely to benefit. We saw it in this study. I don't think you have the curves of the PD-L1 positives, but they clearly separate. And
just
the hazard ratio is like 0.5 or something like that, which is, pretty good. Similarly, we saw in Keynote 427, which is the Pembro non-clear cell trial, you were 3 times more likely to have a response if your tumor was PD-L1 positive. So there's more enrichment there. It's not good enough to use as a strict biomarker, but if you're trying to decide, essentially what the question is do you give PD-1 VEGF or PD-1 CTLA-4, and you're concerned about CTLA-4? Well, if you knew the patient was PD-L1 positive, you might be more willing to give
Do you do that in practice? Are you testing for PD-L1?
Well, here's the thing. I have not been testing up until this point. But if you're trying to understand the rationale for exposing a patient to more risk, I'd want that information. That information would help me going forward.
Which test would you use, David? TC or IC staining?
TC. This has been conducted with TC staining.
And that's the one David's going to use. Because that's not what most Globe's not using TC
Correct.
staining, because the lung program in most
Correct.
hospitals don't do TC staining. So asking for PD-L1 in a hospital, you get lung PD-L1.
Right, correct.
And
I mean,
that's not TC staining.
You just have to explain
You can
that
do
to
it
your
in
pathologist.
Dana-Farber, and you can do it in Gustave-Roussy, but I suspect in Southend busy hospital on Tuesday afternoon, when you ask for PD-L1 staining, you're not going to be saying, oh, it's for papillary renal cancer, we need TC.
Honestly, this is exactly what we've been routinely doing in the CARE1 study, which actually stratified on the TC. And yes, you have to say to your pathologist, hold on, this is TC, and it's a no-brainer. You need to be quite mindful in the way you ask, but they're doing it without any issue.
Yeah, the other biomarker, if I may just say, should be sarcomatoid, right? There's a weird breakdown that sarcomatoid seems to be its own histology.
Yeah, they didn't really pull it out here, and it was a small number of patients.
It just said sarcomatoid, but that is not its own
4.5%.
histologies,
Agreed.
right? So that's something that needs to be addressed.
Agreed.
Right.
Right, we've got a question in the
Oh,
audience.
Matt.
Yeah, so just on this slide, I think to me what was really reassuring is the 3 and 6 month OS in addition to like the first year landmark, where you're not seeing this dramatic drop off in the Nivo-IPI that raises a huge red flag that there's a subset you're clearly hurting, don't have time to transition over to a TKI, clearly not seen here. And so I think that was one of the reassuring things of this trial as well.
Right, I think
Good
Matt
point.
brings up a good point. Is I think we've been getting, maybe this isn't exactly what he was saying, but I think we're getting better at giving Ipi-Nivo than we did with 214.
Patient selection.
Or sunitinib's not very good.
No, I don't. I
Well,
think
the response rate was actually 20%, which is quite remarkable.
yeah, yeah.
In the MD Anderson group, it wasn't as high as that in their cohort. David, you go. I've got something to say. in a
We're
second.
getting better at managing the acute toxicity than we were, 5 or 10 years ago. We're also continuing to give maintenance, even if patients don't receive all 4 doses. To me, that's why partly why this data looks good, but it's also why the Cosmic 313 trial is the best Ipi-Nivo trial ever performed.
Okay, let's not go there.
Let's
This-
not go there.
this-
So my go back one for me. My concern around this is that in the papillary group, and I don't love subset analysis, and I don't think overinterpretation of forest plots is a good idea.
But I'm about to do it.
No,
No.
but there are exceptions to that. And when you're including groups of patients into a study where perhaps they shouldn't be included, so if you did a pancreas cancer trial and you included a whole lot of testis cancer patients, then, and you gave them GEM-CIS, you'd have a cure rate of 20%. And then you get this broad label in testis, because 20% pancreas cancer cured by chemotherapy. And so, but the same, including chromophobe patients in papillary renal cancer, they're as different as each other. And so why when our trial design, and don't get me, I love the trial design because it's investigator-initiated, it's a massive undertaking, it's 300 patients, it's randomized, it's immune therapy, it's a brilliant study, it's a great study. And we couldn't have done this in the UK. And I think hats off the Germans, the pharmaceutical industry, I think it's brilliant it was done. But you do have to look at that papillary subset. That's the most of the patients that we see of metastatic papillary renal cancer, and it's not doing anything. And so I have this concern that we need to get away from the term non-clear cell renal cancer as a matter of urgency. And I'm afraid that if we all agree that we do need to get away from this term, then these non-clear cell big trials where the big subset that we're really interested in looks different is a big problem.
So I agree. So we need to have more granularity. There are a lot of questions and data buried in here that I think are going to be very, very useful. I don't know when the trial started, right? It must have taken some time.
Yeah, 5 years ago.
So that was before we knew that chromophobe doesn't really respond to immunotherapy, et cetera, et cetera, et cetera. So kudos to the Germans.
Absolutely. I'm not being critical of that. I'm just saying we should look at the subset. So I'm not being critical of
That's the point.
I am not being critical of the trial. I think it's brilliant, and kudos to them for doing it. But I think we have to interpret the results with the information in front of us and just not say, because it's positive everyone.
For sure. So would you just, moving forward, if you were to repeat this effort or a similar effort, would you just do it in papillary?
Yes.
And so
I
there'll
have
never
a-
be a trial in any of these other histologies?
Or I'd do a primary endpoint, so I'd design it.
Powered for
Powered
papillary.
for papillary, allow the other patients in as well, primary or
enough.
papillary, and then a wider subset. That's how I would probably do it.
Fair enough. This is the PFS, no difference in PFS, 5.5 months, obviously less than in clear cell. PL1 also seems to sort of enrich here. Here you don't see that difference in chromophobe that you did in OS. And again, I think we just get into trouble by interpreting subsets. I think this sort of this is a little bit sobering, right? You're just like, oh, ipi-nivo's active, it's active. Then you look at this, and you're like, well, it's not that active, right? We don't know if there's a tail. It's only 2 years of follow-up, and obviously it's a lot of censored and limited data after that. Let me ask David, have you experienced or do you think one of the reasons to give ipi-nivo in this subset is the tail of the curve, your durable remission, TFS, whatever you want to call it? Is that motivating in this disease, so to speak, versus clear cell?
Not based on this data set yet, but as you pointed out, we need to see more maturity of this data. But to me, that's the main reason for adding other agents to PD-1 is to enhance the impacts of the drugs after the median. That's the IO story. It's all about tails of the curve, ability to stop the drugs, ability to live in remission, treatment-free survival, that sort of thing. We may see difference in these curves, but even if the difference in the end was 5 or 10%, for certain patients that might be worth it. And that's why you'd have that discussion, and that's why maybe you'd want to use biomarkers to better identify those patients.
David, you did a study called 427. In that trial, single agent, you looked at the papillary cohort in that trial.
Correct.
And in that study, about 150 patients, you showed response rates of 20% and PFS of exactly the same. Single agent Pembro, indirect comparisons, quite big numbers, all the shortcomings associated with that. Is IPI doing anything, or is this all driven by single agent Nivo?
Right, so I appreciate you quoting the study. The numbers you reported were not.
Were mildly, they were right. They were broadly right. They're broadly right. They
It
are
hasn't
broadly
stopped
right.
him before.
But
David.
no, that's fine. It's
But they
fine.
are right. I think they are right. I think they are right. I've done a little graph.
I'll
I have
gladly
it
show
on-
you the
yeah.
paper after
He's
the
got-
recording.
I have
He's
it
got
on
the
the next
graph. He's
slide.
got the graph coming up.
All right, go show to the next slide then. Bring it on.